Welcome to today's Healthline webinar from the American Association of Kidney Patients, titled Research Uncovers Patient Insight into What is Important to Them Accepting a Donor Kidney. Thank you for joining us. My name is Jerome Bailey. I am AAKP's Director of Patient Engagement and Advocacy. AAKP Healthline webinars fall under our Center for Patient Research and Education. We believe patient and care partner education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing health services, assistance program, and access to new products and services. We built this center with the latest polling and engagement technologies to ensure that kidney patients take a central role in informing federal, academic, and private sector research shaping the next generation of healthcare services, assistance programs, and innovative new treatments, and encourage you to respond to our flash surveys and other engagement opportunities that you receive via email as a member of AAKP. Let's get started. I'd like to introduce Richard Knight. Richard is the immediate past president of AAKP, who is also a former dialysis patient and current kidney transplant recipient of 16 years. Richard has diverse experience in public and private sectors in finance, accounting, business development, healthcare, and nonprofit. Currently, he is a business strategist providing patient engagement consulting for healthcare organizations and businesses developing tools designed to leverage patient input and preferences in their care plans and quality measures. To provide background on today's webinar, I'd like to turn it over to Richard.
Thank you, Jerome. And hello, everyone. As the oldest and largest independent patient-led kidney patient organization in the United States, AAKP is proud to host this webinar as a service to our fellow kidney patients, family members, care partners, healthcare professionals, researchers, and policymakers. As you know, AAKP is a champion for full patient choice, which includes the protection of the patient-donor relationship and the elimination of barriers for patient access to available treatment options. We're nationally known for promoting transplants as the ideal therapy over dialysis for patients who are medically eligible. That's why we're proud to partner with professional organizations such as the American Society of Transplantation and the American Society of Transplant Surgeons to advance the field of transplantation through research, education, advocacy, and policy. Personally, I've had the opportunity through AAKP to serve on a number of committees and projects that focus on the advancement of transplantation, such as the Scientific Registry for Transplant Recipients and the Kidney Precision Medicine Project, to name a few. Today's program is exciting, folks, as it features some current research that is conducted to help us understand why a large number of donated kidneys are discarded, and also taking a look at the patient preferences regarding accepting less than ideal kidneys. These findings hope to provide insight on how we can lower annual kidney discard rate, which means we can ultimately lead to a reduction in waitlist time, and most importantly, more patients being transplanted. Now, it's an honor for us to have Dr. Sanjay Mehrotra of Northwestern University, who is the lead on this research project, on today's webinar to share the study outcomes. Through AAKP's Center for Patient Research and Education, we were honored to be able to support Dr. Mehrotra's study by helping to provide unique patient insight data, and lived experiences. Now, following the webinar, if you haven't already, we encourage each of you, to read the paper titled Patient Preferences for Waiting Time and Kidney Quality that was published based on this study. and I had the honor myself to be a co-author of this piece. So, without further ado, let's toss this back to Jerome so he can get us started. And again, thank you for joining us.
Thank you, Richard. It is my pleasure to introduce our speaker today for today's webinar, Dr. Sanjay Mehrotra. Dr. Mehrotra is Professor of Industrial Engineering and Management Sciences at Northwestern University. He is a fellow of the Institute for Operations and Research and Management Sciences and founding director of the Center for Engineering and Health, which is part of the Institute for Public Health and Medicine at Northwestern University. Dr. Mehrotra is an expert in methodologies for decision-making under uncertainty and its application to problems in health systems engineering. He has made major contributions to areas of health system engineering, operations research, and optimization methodologies for which he is known internationally. He has done extensive work in the field of transplantation and is currently studying ways to reduce discard of deceased donor kidneys. Welcome, Dr. Mehrotra. I turn things over to you.
Thank you, Jerome, and thank you, Richard. It is truly an honor to be making this presentation today. I want to say one thing up front. I am a patient, not on dialysis, but I have had diabetes for more than 25 years, and I'm trying to manage it. I could have been easily on dialysis if my own management protocols weren't developed the way I ended up using all the information that was out there to help myself. Moreover, because of poor management early on, about 20 years ago, I actually had a quintuple bypass surgery. So I feel extremely lucky to be actually living at this point. At the heart of my heart, I want to make a difference in patient lives. This particular project was something that naturally came my way as I started working in the area of transplantation. Patient preferences, in my heart, are important and oftentimes completely ignored in the decision making. This particular work that I will be presenting was supported by National Institute of Health under an R01 grant that started 4 years ago. Hence, a lot of what I will be presenting today has actually matured over these years, where I strongly feel that we are at that point where the research outcome can actually be translated into practice. And presenting it through AAKP is, in my mind, a target of opportunity. So thank you, AAKP. I need to disclose some commercial relationships. I am partly helping Quantitative Health Solutions, LLC, but the work I will be presenting has no relationship with the effort happening at QHS. I'd like to thank many of my collaborators without whom this work would simply not be possible. And particularly, I want to highlight Richard Knight for facilitating data collection through AAKP, and also to the patients who responded to many of the surveys that were done. And Richard, thank you again. And at the same time, AAKP staff who facilitated conduction of those surveys. As of yesterday, 88,000 patients are waiting for a kidney transplant. Particularly, many of those are on the wait list because of not finding a living donor and hence needing a deceased donor kidney. This entire presentation will be focused on deceased donor kidney transplant. Last year, 6,000 patients died waiting for a transplant, and another close to 6,000 were too sick to receive a transplant. At the same time, more than 6,000 deceased donor kidneys were not transplanted. This data came as of yesterday from OPTN's website. Hence the motivation. Some of these kidneys could benefit waitlisted patients who are currently not being used. And more specifically, understanding patient preferences regarding accepting what I'll call right now as a loose word, marginal quality kidneys, which are currently not being used. And we will get a little bit more specific, but not very specific, as we go into this presentation in terms of defining what I mean by marginal quality kidney. So this is motivation thinking over long haul. So last year was not an exception year because we were COVID and possibly that could have exaggerated. This issue about kidneys not getting transplanted has been long-standing. More than 20% or nearly 20% of the deceased donor kidneys are being discarded each year in US prior to 2022. And in fact, you see an increasing number of these kidneys getting discarded, while waitlist has hovered around 90,000 patients over these years. Now, I want to explain to you a little bit about how patients get to a deceased donor kidney. This is a rough approximation. Patients who are waitlisted, you get points. The points are there for sensitization, prior donation. Then there are rules that are based on mismatches of the biological mismatches like HLA mismatch. There are some additional rules about post-transplant survival of patients, and there are some factors around geography of where a patient is waitlisted. However, for the purposes of this presentation, what matters the most is waiting time on the waitlist, and more specifically, time accumulated by the patient since the patient is put on dialysis. That obviously changes over time. CPRA can change too, but that is the dominant changing on wider patient population, which basically grows depending on how long somebody is waited. So person who's waited for a year has accumulated, say, 1 point, and every day adds to 1 over 365th point the patient is waited. So longer somebody's waited, they've gotten more points. Consequently, they are higher on the priority list for receiving a transplant. As Richard alluded to, donor kidney quality is not necessarily the same. There can be many factors contributing to it. For example, donor age might be one of those, but that's not the only factor. Thinking about it from the perspective, very broadly speaking, of quality, one can think of it as post-transplant functional function of the donor kidney. A good or really good quality kidney might be functioning very well for 15 years, for example. Richard gave an example of himself. And then as it deteriorates, actually functions for an extra so many years, till the patient needs to come back on dialysis. And this can happen for a variety of reasons. You can have another kidney that can function for, say, 8 years quite well, and then goes through a similar kind of phase where its performance deteriorates, and can have a even more marginal kidney that actually has functionality, excellent, or at least functionality enough to have patient not on the wait list for a certain number of years, and then subsequently deteriorating its function. Now, compare that to a patient on dialysis. You have this patient on dialysis will be surviving a certain number of years, and the bar in this figure are kind of rough reflections, just to get the point across. There's a metric, because I'm going to be using this vocabulary more often as I proceed in my presentation. There's an expression called kidney donor profile index, which is a number between between 1 and 100, and the KDPI measures as a number, if you like, the quality of kidney. And just to get our brains reoriented, a larger number is actually saying that it's an inferior performing kidney post-transplant. So a kidney which has a KDPI of 80 has 80% kidneys that are better than the one at hand. One actually has a KDPI of 40 has only 40% kidneys that are better. So in our brains, we should think that lower is better from the perspective of post-transplant kidney functioning. Now, there is another kind of expression underneath what's called kidney donor risk index, which leads to calculation of KDPI. And this KDRI expression is a formula-based expression that incorporates many different variables. I mentioned age before, but for now, for our purposes, we're going to just think in terms of summary statistic that is encapsulated in KDPI. So from the perspective of KDRI, I'm going to just use, this is the only slide where I'm using KDRI. As you can imagine, kidneys that have a higher KDRI, so they have a higher KDPI, they actually are more likely to get discarded. And this figure is essentially illustrating that. So kidney that has a lower KDRI, they're going to get transplanted. I want to acknowledge the borrowing of this slide from a slide deck that was part of an NIE, was Institute of Medicine report. Did analysis a while back, several years ago, where we said, depending on patient's functional status, how well the patient is doing health-wise, is it better at the national level where having a kidney, which is the worst possibly, or of a certain KDPI value, be transplanted to that patient in terms of it outperforming dialysis? I wanted to summarize this finding here. So we have in this panel 3 types of patients. One is completely healthy, more or less takes care of himself or herself, independent of any support. Then we have a category where the patient's functionally deteriorating, needs beginning to need more help, and then a patient group that could be less functional, needs significantly more support. And the larger number here is worse. By the way, the label here should be a slight correction on the label on the last part. It should be between 0 and 60. And I have to just summarize the finding. For every single group of these patients, our finding was that an average patient who's in the data that was provided to us, this patient would actually benefit from a transplant over dialysis. So it's not like there is a patient there's roughly an average patient who wouldn't benefit. So there's somebody out there, interpret it this way, who will benefit from this kidney. And we want to make sure that we get to this patient fast enough while hopefully incorporating their preferences so that these kidneys, which are more marginal, can get transplanted. Now, one more nuance in this is that not every kidney gets transplanted. When it is donated from that time till it's actually in the recipient's body, so to speak, what's called the cold time, they don't get the same amount of cold time from donation to transplant. This panel is showing how different those times can be. For now, we will not get into the nuances of, well, how can we actually improve the logistics of this cold time? But this whole vocabulary of cold time is important in this as a summary statistic. In the context of marginal kidneys, we're going to try to think it in terms of how we can change the national policy, although I love to see the logistics improve too, in terms of trying to get these kidneys in hands of patients in need faster. So as a background, that is the big picture goal, while the context would be incorporating patient preferences. As you can see, a significant fraction of these kidneys are actually taking longer than 24 hours before transplant. So major reason for cold time, I mentioned before, logistics is one, but it's the nuance in the national policy that basically says each donor kidney at a transplant center can get provisionally accepted while it's being further evaluated by clinicians at the transplant center, and subsequently communications happen with the patients before it's finally accepted as candidate for transplant into a specific patient. And this provisional to actual time conversion basically allows for half an hour, and that half an hour accumulates over time, and that in principle is something that delays or could delay transplanting of a kidney. If there was very clear yes from get-go, patients, the right prioritized patient was actually getting the kidney in hand, we could potentially cut that time significantly. And of course, I mentioned logistics before. So at the end of the presentation, I'm going to get back to this issue about time. As you can see, hold time for kidneys at a time when it get transplanted is larger for high KDPI kidneys because it goes through a bunch of provisional acceptances or many more provisional acceptances than the ones that are actually better quality because they are, that's the nature of decision making. Again, this is the average on the y-axis here. You can see that some of these kidneys, which are really marginal, is taking more than 20 hours before they get transplanted. And these are the kidneys for which, as you observed from previous slide, have the largest discard rate. We did some early research and publication. This is in the same journal where we have the preference paper published around the same time. We're basically saying that if we can cut on our decision time, we can potentially have greater acceptances in the current transplant system for getting these kidney transplanted. So overall, what you call acceptability of these kidneys reduces significantly with every 2 hours, say, of reduction in that cold time. And this is a very large scale data analysis exercise. It didn't involve any preferences, but I will be kind of contextualizing it because we could do retrospective data analysis, but what really is important is to actually think something prospective. One more issue that will come up and was alluded to before is how much time a patient waits. And as you can see in this slide, patients at the time they get transplanted till they start accumulating these waiting time points, it's really a large range here. Quite a bit of transplant that happens within 6 months of listing, and quite a few patients get transplanted after more years, more than 8 years. Again, that's in itself a project that I spent some time on early on, but it's going to be an issue that will be discussed. Again, a game that we would like to talk about here is how can we really get marginal kidneys transplanted to patients in a way that it actually incorporates patient benefits and also yields better outcomes. So then, with that background, we are now thinking research questions with patients' perspective in mind. Questions like, would you be willing to take a marginal kidney if it reduced wait time? If so, by how much? What is the wait time reduction and kidney quality reduction trade-off that one is thinking about at the back of one's mind? Or who is willing to take marginal kidney if their wait time is reduced? Not everybody may be interested in that. Is there willingness on the part of patients and clinicians to place a marginal kidney on a fast track so that certain patients, possibly the queue can be jumped for them because of this delay that happens of half an hour? You wanted to get some temperature of that. And then how many more marginal kidneys will get transplanted if only these marginal kidneys were fast track? We'll try to answer all these 4 or 5 bullets as part of this presentation in the remaining time. So this slide is a little bit crowded. We want to make sure that we are more precise when we're conducting research. This describes in patient interpretable language because we early on found that a lot of patients don't even understand what KDPI is or what KDRI is. So we translated some of the specific numbers into something that is more interpretable, where we said, well, there's an ideal kidney that has a low KDPI, there's an average kidney, and there's a marginal kidney. So now there's a more specific definition to it, and it puts numbers behind what will happen to this kidney after transplant in terms of its functionality. And so, for example, a KDPI 21 to 85 kidney will continue to function 75% of the time after 5 years, or whereas only 62% of these kidneys that are in the larger than KDPI range will continue to function after 5 years. Again, as part of the research, we designed first is a general survey to understand patient perspective before we even getting into subgroup analysis type survey, where in this particular scenario, we said, well, can you just give a rough idea of what will be the willingness of acceptance? So let's say if patient reduces patient's wait time is reduced by 2 years, patient's already on the wait list for 3 years, patient gets a marginal kidney. Again, remember that's a high KDPI kidney, which is 86 to 100. 100 is the worst kidney that gets kind of offered in the previous year. And the clinician who you're interacting with, and of course this is kind of going back and forth, is told that the marginal kidney is available. It will be most likely sleepy. So I want to say a little bit about that. So basically, a lot of times marginal kidneys, some of them may just work right out the box, so to speak. They really start to do their job, whereas others may take 2-3 additional years of dialysis before they truly wake up and start performing, doing their job. So we try to make things worse in a way that we didn't want to present an optimistic picture, because that would have been really concluding something biased. And we said, well, if this is your situation, would you be willing to accept such a kidney? And the answers were pretty easy, right? Yes, no, or maybe. And this really, in my mind, was the eye-opener. And it's part of a paper that was published early on. 70% of those responded. In this case, this is all conducted through AAKP. Hundreds were responded, and we were very strong in terms of inclusion criteria that we had in terms of selecting the survey respondents. Of those responding were on the wait list, 70% or 71% to be precise said they'll take it. Only 14% said no, and only 14% said they would need more information. You can imagine that with that for additional needing more information, once communications happen with the clinician, might turn into yes, oh, I'll take it, right? Maybe another 7%, maybe another 10%. I don't know the answer, but here is the data. Okay, so what in a different way, what I'm saying is that roughly about 70 to 80% of the patients who are on the wait list are willing to take these marginal kidneys, should it reduce to 2 years of wait time, having had listed for 3 years, or having had their dialysis started for 3 years. Then we said, okay, we're going to make this kidney even worse. And let's see how this thing changes. So again, in research, we try to do some sensitivity analysis just to see how our findings are in terms of, things worse, particularly, which is where it really matters. If we had made it better, I mean, of course, the number should go improve further. But in this case, we made it worse. He said, look, okay, fine. I mean, the kidney is not going to perform out of the box. They'll be sleepy. It might wake up in 2 to 3 weeks. But at the same time, the functioning over the next year, let's say, will be, needing more patient visits to the clinicians. Okay? And let's say if it's got, if you understand some of the technical vocabulary, the GFR, filtration, like kidney filtration rate, let's say if it is between what will put somebody on dialysis, like say between 15 or 20 to 60, as compared to like greater than 60. Greater than 60 is much more like perfect functioning. But let's say if it's even 60 or 70, but it does need additional patient visit. Okay. So we want to understand that aspect. And this was really eye-opening to, at least to me. I said, wow, still there are 40%, 45% patients out there who have waited for 3 years. They would take these kidneys if they could save 2 years of their dialysis time. So the next question was, will you be it will be acceptable for you to get bypassed? Now this is for from a broader consumption perspective, because we want to save time on these marginal kidneys. And I said, well, would it be completely acceptable, would be somewhat acceptable, unacceptable, and so forth. So it was a Likert scale that we decided that would be appropriate for getting the responses. Okay? And we wanted to simultaneously get the temperature of the patients and on the clinician side. And by the way, on all the previous things that I mentioned, we had a version of it for the clinicians as well. We just, I'm not presenting that here. So that's why you see some of the clinician numbers. The two surveys were slightly different, but the next slide will show that at least for the purposes of changes in the intended policy change, we wanted to get kind of some consensus there. What we also found was of the patients and clinicians, in fact, for clinicians it was a little worse, this thing was completely acceptable. And for others, it was somewhat acceptable. So more or less, people who were opposed to it were in minority, like 5-6%. And this is complex decision making that needs to happen at the policy level. We're not going to go there yet, but I'm hoping that down the road with AAKP's help, we can really translate some of these research to practice. There was one more nuance that's relevant. So again, remember, some of these kidneys might be sleepy. Not every kidney will remain functional. Some might just not function at all, even within the first year. It's always that possibility, even for low KDPI kidneys. We said, well, if that happens, what is the willingness to reduce that roadblock? Because we don't want the patient to come back on wait list, ideally, but there's a possibility, and there's going to be a greater possibility for these patients to come back on wait list. So the compromise solution is that, okay, this patient may come back on the wait list, but we shouldn't be penalizing a patient for, accepting a marginal kidney, right? Which actually happens in the current system, where the patient who gets this marginal kidney completely loses all the points that they have accumulated for the waiting. So I said, okay, is there a willingness to give some of that waiting time back? And this is also remarkable. Patients, 50% were willing to give 100% time back. It's because really, those who are patients, who are listeners, strongly supportive of this concept. And 75% of the time back was also another, I would say, 18%. And half the time back was another 25%. Again, those who are really wanting to penalize, even for marginal kidney, for transplant, again, in minority. Remarkably, in fact, patients are more generous in this case than clinicians. I do not know why, but these are the findings. All right, so now we're getting more complicated. I have to explain this to you. We're saying we have these kidneys. We actually have certain level of quote unquote regular function post-transplant, and we changed that number from 8 years to 2 years in certain step sizes. And similarly, we have for these kidneys time for low function. We changed that between 5 years and 2 years, and then waiting time for kidneys that one can be shaving off anywhere from 0 to 50. 0 is just a reference, to 5 years. And essentially, we wanted to do more complicated analysis. We wanted to understand really the waiting time to reduction in KDPI trade-off, so that we actually are bringing more science, if you like, into this. And many more of you responded because there was a larger catchment pool that we had, because we relaxed some of the inclusion criteria in this case. So, for example, patients who actually had received the transplant, and those who were still waiting, they were both included. Both groups were included in the survey that we did through AAKP. We did an additional survey through Northwestern University, where I had access to patient emails. Again, by the way, AAKP was completely anonymous, but again, everything was completely anonymized. We kind of supplemented the data that we got from AAKP through data we received from same survey that was done through Northwestern, to kind of bring more power to our analysis. By the way, the two groups responding in characteristics between AKP respondents and Northwestern respondents were not very different. So we could do this more rigorous analysis so that I can make more stronger statements about some of this wait time trade-offs. So for example, in the previous results, I said, well, 2 years and 3 years of waiting, but maybe patients wait at different time points, and they may be at a different transplant center, and maybe the shaving off the wait time is only 1 year. Versus say 2 years, versus or shaving off the waiting time maybe 3 years, 4 years. We don't know right now ahead of time, right? Because the patients at certain transplant centers could be waiting longer than others. So we did what's called discrete choice survey, where again, remember I mentioned before, most patients don't understand what KDPI or KDRI is. KDRI is only more complicated, right? And we said, okay, we're going to do it in a way that is very comprehensive. So we designed this choice. We said, look, you have waited, you are at a time point where you have a choice between getting a kidney in the future, and didn't specify here how long, that was in the previous panel, and so we could change it. And the kidney today is, time of 3 years of regular function, and then change the time with low function. So we had that as a question. Another example, we actually have a different kidney, and you also basically respond by saying either wait today, take the kidney that's our offer today, or wait for that longer. In this case, wait for a year, but that number changed. Okay, and basically the response was in one of these two response choices. That's a very rigorous way to think about how we'll be getting patient preferences. This is the statistic on the respondents. We had 600 patients who were surveyed. Mean age was 61 years. Of those who responded, there was decent diversity among the respondents. We unfortunately were underrepresented from Latino or Hispanic patients. We tried our hardest to get that representation up, but I think we have some speculation on why that was the case. But certainly between the white, Caucasian, and African Americans, we had a representable response percentages. We are slightly overrepresented in the patient population who actually had a college degree. And in this case, we had significant respondents who were actually low income. And this respondents, again, we were somewhat, there was roughly 25% of the respondents had a waiting time they were waiting for the first kidney, whereas the remaining have had a transplant before. So that's how our pool got enlarged. But some of this, maybe not even a full representation of the respondent demographics or wait-listed patient demographics, was perfectly okay for the purpose of conclusions that we wanted to arrive at. Average respondent was willing to forego roughly 4.5 years, let's say 4 years, of regular function of a kidney for a 2-year reduction in waiting time. Now, if we increase that to 4-year reduction, we were willing to forego almost 7 years of regular kidney function. So go back to the earlier slide. Remember, the higher KDPI kidney, there's a compromise there. The regular kidney function time reduces significantly. And I was saying, look, even if this reduces by 7 years, so the kidney, instead of working for 14 years, so let's say it works for 8 years, okay, even worse, maybe working between 12 years versus 6 years, there was willingness. to actually make that trade-off. So we have willingness to accept from before, this willingness to trade off the time, waiting time for regular function. Now, what we wanted to do is more detailed analysis. Who are these people who are actually more willing or less willing to want to take these kidneys now, if they're marginal compared to those who really, okay, they want to wait. So we did this so-called secondary analysis, and this is a little bit crowded slide, but what I want to highlight here is that let's say we have a group, 60%, they've got somewhat more willingness to take the kidney. Now, that's marginal quality right now, but we want to compare that with a group that really wanted it now compared to those who really don't want it. And what I want to highlight here is the group 2 and group 3, where group 2 actually are older patients. Their health status is worse compared to group 1, African Americans without a college degree. So now not everybody is the same. So this is a much more sophisticated analysis, but those are the 4 attributes, if you like, of those groups, of that group who's willing to take more of these kidneys. Whereas we had a third group, which actually is younger. So minus here means 62 or 61 or younger. And they were already on the wait list before they had even started on their dialysis. And that is possible, right? Somebody can be on the wait list before dialysis starts. The waiting time only accumulates when somebody's dialysis started, but the transplant centers can list patients sooner than they've been put on dialysis. At least group 3, there's a natural explanation of why they would want to wait for a marginal kidney. Okay, so now we wanted to see if we can translate this into so-called the balancing act and see how this is going to be improving our overall transplant system. So for now, without getting into the political side of things, there is a trade-off between how much more time should be allowed to collect and analyze patient information and contact patients to actually make these acceptance decisions, and cost of doing that at the transplant center is one side of it. So time is like half an hour, if you remember from before, for each patient at a transplant center, whereas the trade-off is it is being traded off with the time to transplant a kidney early enough to save discard because of many of these marginal kidneys. Remember, the marginal kidneys end up accumulating a lot more time compared to higher quality kidneys, which, if you remember from before, do get accepted sooner anyways. So we wanted to see if we could actually shed some light on that question, so that we are now trying to build a bullet-tight case so that we can get many of these kidneys, like the original aim, in the hands of patients whose life is going to be saved by these kidneys, instead of letting them really die on dialysis. And they are interested in taking these kidneys. Remember, those are fundamental things that we want to get solved. What we're saying here is the following. So let's say we let the kidney be offered. So we want to have to make the compromise between fairness for the patients, and then also that against reducing this waste. And as an industrial engineer, I hate waste. Okay, whether it comes in this case, really lives saved is waste, which is kind of holy grail. I mean, even we teach waste reduction in operations in general, and this transplant programs, it's like a huge operation, most complex thing I've ever encountered. More so than running airlines, let's put it this way. So what we say is that in this slide, we want to try to make the choice available to the patients and all the transplant centers early enough after they've accumulated the wait time, anywhere from say 5 hours of kidney accumulating the wait time till say 20 hours. Okay, and we see how in a simulated environment, one will be reducing the number of these marginal kidneys getting discarded. And the vocabulary right now that's being used is non-utilized, and that's, I think, because of request of one of our co-authors. We want to make sure that, there are not every kidney, by the way, let me just go back and make that statement, which is not being used, is viable, right? So there are a bunch of these kidneys which are viable, and we have done some earlier analysis. We said we can really predict early on which will be non-utilized with a very high degree of confidence. In the interest of time, I didn't present that. Translating that previous one into numbers, just among the high KDPI kidneys, this is the worst 15% kidneys. If we were offering them at 5 hours of cold time and put that in the hands of the patient who's willing to accept it, we will be in a position to save 1,500 of these kidneys, at least 1,500 of these kidneys. Now, this data is old because all of the systems built, this is a giant simulator that we built using national data, where we basically looked at all possible things that can go wrong in the worst possible way, and before coming up with these rigorous conclusions. So, for example, we see like each hour is having this like multiple points, just because we wanted to do all sufficient sensitivity analysis before drawing any conclusions. So we said, yeah, there's a significant number of these kidneys. If we are in a position to identify the patients and put them in the hands of the kidney, reducing this call time, they will find somebody this willingness to accept, and consequently saving all these lives. And this uses all the historical data that we could do to build the models and so forth. So I wanted to sort of say this because I think at the end of the day, there is somebody out there by doing things whose life we know we can save. We don't know whose, but and I know that way that grateful patient wouldn't necessarily be the person who will be thanking me, and that's okay, perfectly with me. I'm an engineer. I'm not necessarily on the front line. Clinicians are typically, but as a policy, I think we can make a difference. And I think what I'm talking right now is a demonstration of how things can really be done if the right science is brought to sort of collecting evidence, so that we can make an evidence-based decision making and changes. So I want to conclude with some bullets. Patients are willing to accept marginal kidneys. Patients are willing to help others for allowing expedited treatment, which is for now I described it as open offer. More patients are willing to make trade-offs. And there were 3 distinct classes of patients, of which one that actually is lesser education, African Americans, basically lower income. They were willing to take these kidneys, and particularly if their functional status is deteriorating. These findings suggest that first, transparent communication to patients can happen or should happen, where treatment preferences can be incorporated in the system decision making. Have individual patient preference information at hand if it can be done. So right now this is still research. We're hopefully going to be thinking about how can we further work on translating this. It's still at the research finding presentation level. And in the clinical practice, it could really complement the current consenting process that is happening for high KDPI kidneys. Right now, there is a process where a patient can say, I'm willing to take it versus not. And we're doing some more analysis around that as I speak. And I hope I've ended in time.
You did great, Dr. Mehrotra. We really appreciate the presentation, and thank you for sharing on the patient preference for waiting time and kidney quality of research today. We appreciate it.
Thank you.
It is now my pleasure to introduce Janice Starling. Janice is an AAKP ambassador from Florida. Her kidney failure was caused by uncontrolled hypertension. Janice has experience with in-center dialysis, peritoneal dialysis, home hemodialysis, and received a kidney transplant in December of 2013. She works at her family-owned childcare center where she is a pre-kindergarten teacher. She's also the founder of the All Kidney Patient Support Group, a local nonprofit organization founded to help other kidney patients in the community and bring awareness and education about kidney disease. Janice joins us to share her kidney journey and why she accepted a less than perfect kidney. Janice?
Hello, I am just so happy to be here today. I am so excited to realize a lot of the things that the doctor talked about. I experienced those treatments. And Jerome, did you have some questions you wanted me to ask, or you just wanted me to go ahead and start talking?
Yeah, Janice, just go ahead and start sharing your kidney journey, please.
Well, back in the year of 1999, I had a late bite kidney doctor. I had a late bite primary care doctor, and he was like, Miss Starling, you have a little protein in your urine and you're going to be fine. And 6 months later, that was around in maybe June or April of 1999. And in April of 2000, I was diagnosed with kidney disease. I had no idea that protein in my urine was causing me to have kidney disease. I knew nothing about dialysis. The doctor, when I was in the hospital, the doctor ran a lot of tests on me and it said that he wasn't sure. And then all of a sudden, he just came in the room and said, Janice, you have kidney disease. You'll be a good candidate for peritoneal dialysis. And I was like, I didn't know what that was, and I had no idea. So it was back when they had VHS in the hospital. I had to have someone bring a VHS TV so that I can watch a training on dialysis and to watch information about how do you cannulate yourself and what was dialysis, what was peritoneal dialysis. So at the same time, when I said, if you're going to do surgery, go ahead and do my fistula and do my shunt for my catheter for my peritoneal dialysis at the same time. I said, just let me experience one set of pain so I can be done with it. So after that, I went to in center. I had to go to in center. They had a catheter in my chest. I did that, and I started with my CAPD. Where I did continuous ambulatory PD, and then from there I went to the cycler. I did that at night. I did peritoneal for 3 years. I traveled with my machine. I love the freedom that it gave me doing the peritoneal dialysis. I just really loved it. At the same time, I was on the transplant list. My doctor, when he first told me I'll be a good candidate for a transplant, he said, but it's your weight. But I didn't have any idea that the solution that I was on for the PD caused me to gain 80 pounds. So once I got peritonitis and I started back in center, I started losing weight again. I did in center for 3 years, and I convinced my doctor, my nephrologist here in St. Petersburg. I found out about home hemodialysis. And I said, can you start home hemo in the center? And he said, well, I don't know. I said, well, if you think about it, you'll be the only center in this area, the only doctor in this area offering home hemo. So I was the first Medicare patient to start home hemo at my dialysis centers once I convinced my doctor to start home hemodialysis. From there, I did 6 years of home hemo. I had a total time of 14 years waiting for a kidney transplant. I was listed in three places, Shands Hospital, Tampa General Hospital, and Miami. And Miami is the center that called me for my kidney transplant. They called me twice, and Tampa General called me once. During that time of waiting, I had no idea about the KPDI kidneys. I remember talking with my transplant coordinator, and she said, Janice, you've been on the transplant list for a long time. Let's see about reducing your time, and would you be willing to accept marginal kidneys? I said, at this point, I'll be willing to take anything because it had been a long time since I was on waiting for a kidney transplant. While in 2010, I attended a workshop at the American Association of Kidney Patients, and I found out about IVIG medicine. At that workshop, I was told that it was a medicine that reduced the antibodies. Well, my third year, let me back up a little bit. My third year in 2003, they thought I had breast cancer. And I knew I was on the transplant list. And I said, well, let me go ahead and just remove my left breast so I can make sure that I don't have any problems on the transplant list. Well, when the doctor performed the surgery, he ended up leaving a capillary open in my blood and didn't seal it off well, and I was internally bleeding. Well, during that time, I ended up getting 25 to 30 blood transfusions. So that increased my wait time for the transplant list. So when I heard about the IVIG medicine through the AAKP, that helped me. I went to the each transplant center. I said, have you heard about the IVIG medicine? Miami said, yes, we have. And for 2 years, from 2011 to 2013, I did the IVIG to lower my antibodies so that I could accept a kidney. And I heard the doctor that day when I got my transplant. I was so happy. But I remember my sleeping kidney, and I had to drink a lot of water. I did receive a less marginal kidney, but now it's 9 years, and I have beat his odds and with my transplant kidney, and now I'm living a healthy life. And I just want to thank AAKP for giving me this opportunity to speak about my kidney and my kidney transplant.
What made you say yes to accepting a marginal kidney?
Well, I remember that day. I was in my like 12th to 13th year waiting, and I had waited so long. I was like, I just needed to get my kidney transplanted. I know I wanted it. And I just said, well, just let me go ahead and just sign up for it. I remember sitting and talking with my husband, and we was like, well, let's just go ahead because I had waited. I've already waited 12 to 13 years at that point. And that last year, I said, let me go ahead and sign up for a marginal kidney because I was waiting so long. And the statistics are pretty much right. When you wait so long on the transplant list, you really just want to try something different and live a better quality life. So that was the reason. I just wanted a better quality life, and I just wanted to try something different.
Do you know who the donor was and whether or not, can you talk about any complications you had? And if you did have any complications, how they were solved?
Yes, I did have complications. He did say I still am anemic. I had rejections twice, and it was solved by doing. I had two treatments of plasmapheresis, but that was due to the regulation of my transplant. They trying to the different medicine that I was taking. I was allergic to one of the transplant medicines, so then they took me off of medicine and put me on another medicine. So that was due to me, them trying to regulate my transplant, my immunosuppressive drugs. That's why I had two bouts of rejection. So, but the I mean, the plasmapheresis took care of that. But I still have to see the doctor. I do labs once a month. He did, like he said, you do have. I do go to the doctor more often than a regular transplant person. I do my labs once a month and to stay under doctor care to make sure that everything is working properly.
Now, Janice, we did get a question submitted as people were registering for today's webinar. And a question came in for you, and it is, if I am willing to accept a less than perfect kidney, how would you suggest I bring this conversation up with my healthcare team?
Well, with all of the statistics that the good doctor just showed, that would be a great thing to talk about and to bring to the table. And then you never know what you're going to get. Even I've had people tell me they had a great kidney and it only lasted 2 to 3 years. So I just think everybody's body is different. And with faith and hope and prayer, I mean, you never know how a kidney is going to work. So you just have to really just, put your faith and trust in and just kind of go with what you can and live a quality life. You just really just have to just trust and have faith. That's the only thing that I can say.
Thank you, Janice, and thank you again for sharing your journey with us.
Thank you, Jerome. I really appreciate this opportunity to speak.
If anyone watching has any additional questions for our speakers about today's webinar that we were unable to get to, please send those questions to info@aakp.org, noting the webinar title in the email subject line. I'd like to close today's webinar with a few slides on additional resources that may be of interest to you. First, if you're not already a member of AAKP, we encourage you to join. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a member, join online at aakp.org or by phone by calling 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified by email when opportunities arise where your opinion and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo of kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our printed magazine, AAKP Renal Life Magazine. We also invite you to follow us on our blog and social media for the latest news and announcements. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download, including our Coping, Living, and Thriving with Kidney Disease brochure. You can also order materials by phone. We are excited to announce the dates of our 2023 events. The 5th Annual Global Summit on Kidney Disease Innovations in partnership with George Washington University School of Medicine and Health Sciences will be a hybrid event, both online and in Washington, D.C., and will take place June 28th and 29th. The 6th Annual Policy Summit will take place virtually on July 28th. The 48th Annual National Patient Meeting will take place virtually September 22nd through the 22nd. And the 5th Annual AAKP Fun Walk will take place virtually December 4th through 8th, with an in-person walk in Tampa, Florida on December 9th. We invite you to let us know which events you are interested in participating in this year, and we'll be sure to notify you when registration is open. You can also visit our YouTube channel to watch presentations on demand from our 2022 events and programs. We'd again like to thank Richard Knight, Janice Starling, and Dr. Sanjay Mehrotra for participating in today's AAKP Healthline webinar. Thank you all for joining us today.